Good afternoon, our dear students. Today we continue our cycle of lectures about Propaedeutics of internal medicine, and it is continuer of cardiovascular submodule. And today it is signs and symptoms of cardiovascular system diseases, and especially syndrome of coronary insufficiency. This topic will be combined from two lectures about chronic forms of coronary insufficiency or coronary artery disease or ischemic heart disease, and another lecture about acute forms or acute coronary syndrome. Today I'm going to discuss with you shortly general about coronary insufficiency and a little bit about chronic, and more practical information, more classifications and diagnostic skills we will discuss next lectures in acute coronary syndrome. And plan of our today's lecture, it is discussing of coronary insufficiency, like definition, classification, causes, pathophysiology, risk factors, clinical picture, and diagnosis. What is coronary insufficiency? It is a state in which an imbalance occurs between the oxygen supply and demand, which prevents adequate maintenance of metabolic needs of the myocardium, resulting in ischemia of several degrees of intensity. Classification. As I told, it can be acute. We include here unstable angina and acute coronary syndromes. And chronic. Most often it is stable angina, but not just typical stable angina. It can be a little bit other chronic forms. Acute coronary syndromes are named according to appearance on ECG. We name it a non-ST elevation myocardial infarction or non-STEMI, and ST segment elevation myocardial infarction or STEMI. Acute coronary syndrome should be distinguished from stable angina, which develops during exertion and resolves at rest. Acute coronary syndrome occurs suddenly, often at rest or with minimal exertion, or at lesser degrees on exertion than an individual's previous angina. We name it crescendo angina. The onset angina is also considered unstable angina, since it suggests a new problem in coronary artery. Chronic coronary insufficiency, or stable angina or angina pectoris or just angina, it all synonyms. It is the sensation of chest pain, pressure or squeezing, often due to ischemia of the heart muscle from obstruction or spasm of coronary arteries. The term derives from Latin angere, to strangle. There is a weak relationship between severity of pain and degree of oxygen deprivation in the heart muscle. Worsening or crescendo of angina attack, sudden onset angina at rest, new onset effort angina, and angina lasting more than 15 minutes are symptoms of unstable angina. Sudden onset angina at rest and angina lasting more than 15 minutes usually grouped with the similar conditions at the acute coronary syndrome. And here is a classification of angina pectoris. The most usable classification, it is classification by functional classes of angina. And it can be first, second, third, and fourth, general 4 functional classes. Let's discuss what is this. First functional class of angina. It is ordinary physical activity like walking or climbing stairs does not cause angina. Angina in this patient occurs with a strenuous, rapid or prolonged exertion at work or recreation. And what to do with this form? What specific activity it can be? It is ability to ski, play basketball, jog at 5 miles per hour, or shovel snow without angina. Second, It is slight limitation of ordinary activity. In these patients, angina occurs on walking or climbing stairs rapidly, walking uphill, walking on stairs, climbing after meals, in cold, in wind, or under emotional stress, or only during the few hours after awaking, when walking more than 2 blocks on level ground, or when climbing more than one flight of stairs at a normal pace and in normal condition. And what about specific activity? Ability to garden, rake, roller skate, walk at 4 miles per hour on level ground, have sexual intercourse without stopping. Third functional class of angina. It is marked limitation of ordinary physical activity. Angina occurs on walking 1 to 2 blocks on level ground or climbing one flight on stairs at a normal pace with normal conditions. And specific activity that can do this patient, it is ability to shower or dress without stopping, walk 2.5 miles per hour, bowl, make a bed, play golf. And fourth, the last functional class and the most severe. It is ability to perform any physical activity without discomfort. And what about specific activities? It is anginal symptoms may be present at rest. It is inability to perform activities requiring 2 or fewer metabolic equivalents without angina. Causes of angina. It is atherosclerotic obstructive coronary insufficiency. It is the main cause of angina. More of it can be caused by cardiac valvular disease, especially aortic stenosis, by hypertrophic cardiomyopathy, by the microvasculature diseases like diabetes mellitus or metabolic syndrome or syndrome X. It is anomalous origin of coronary arteries and coronary fistulas. Pathophysiology of coronary artery disease. Fundamental components. It is endothelium dysfunction. I hope you remember that endothelium, it is an organ. It is secreting organ. It contains muscles. It regulates by nervous system and a lot of functions like hormone, electrolyte balance, like tonus of vessels usually controlled by endothelium. That's why endothelium dysfunction usually it is a key pathophysiological link of atherosclerosis and ischemic heart disease especially. It can be obstruction of the lumen of vessel by atherosclerotic plaque, but primary it have to be caused by endothelium dysfunction too. And it can be thrombosis at the location of lesion. Yes, it is the last stage, but the same process. It is a result of atherosclerosis, and atherosclerosis is a result of endothelium dysfunction. In this way, we have stages of this process. The dysfunction of endothelium leads to rapid progression of atherosclerosis, formation of atherosclerotic plaque. It is growth. It is obstruct the vessel lumen, and in this place it can be thrombosis. All these stages can lead to different stages of ischemic heart disease or coronary artery disease. But the decline of coronary reserves starts the lesions occupy at least 70% of vessel diameter. That's why the first manifestation, first symptoms of angina, even stable angina, starts when obstruction is more than 70%. Before this obstruction, if it is better circulation, the organism is able to compensate this hypoxia. Risk factors of atherosclerosis. You learn all of it in your pathophysiology. Let's repeat. It is action of small dense LDL, low density lipoproteins, cholesterol. It is action of triglycerides. Triglyceride level 4 hours after meal. It is decreased high-density lipoprotein cholesterol. It is increased low-density lipoprotein cholesterol. It is increased level of homocysteine. It is protein for abnormal metabolism of folic acids. It is lipoproteins in general, decreased omega, diabetes, insulin resistance, decreased exercise, decreased estrogen levels. It is abnormal wrong diet. It is remote or active infections, increased markers of inflammation, increased oxidative stress, and decreased antioxidant reserve. It is activated platelet function, hypercoagulable states. It is elevated fibrinogen level. It can be visceral obesity, smoking, hypertension, family history genomics, stress, hormonal imbalance. And you see how is multifactorial if this disease atherosclerosis. Just all these together, but maybe not all, but a big part of these factors together can give rapid atherosclerotic process with formation of plaques and obstruction of vessels, and in this case especially coronary arteries with formation of ischemic heart disease. Clinical picture. It is chest pain or discomfort. It is shortness of breath, heart failure, irregular heartbeat, nausea, sweating, decreased exercise tolerance, etc. And by the scheme you see from upper to down what symptoms can feel the patient with ischemic heart disease. It is dizziness, pale skin, sweating, chest pain, shoulder that irradiate in typical places in shoulders and arms. It is arrhythmias, difficulty breathing, and nausea. Clinical picture. It was formulated historically and 18th century by the Dr. William Heberden. And now I have to give you an example how to explain clinical picture of angina, Mr. Heberden, to show you that it's nearly the same for our today's meaning, today's understanding of clinic of angina. By the Heberden, but it is the disorder of the breast marked with strong and peculiar symptoms considerable for kind of danger belonging to it, and not extremely rare, which deserves to be mentioned more at length. The seat of it and sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris. He first formulated this term angina pectoris. Those who are afflicted with it are seizured while they are walking, more especially if it be uphill and soon after eating, with a painful and most disagreeable sensation in the breast, which seems if it would extinguish life if it were to increase or to continue, but the moment they stand still at this uneasiness vanishes. In all other respects, the patients are at the beginning of these disorders perfectly well, and in particular have no shortness of breath from which is totally different. The pain is sometimes situated in the upper part, sometimes in the middle, sometimes in the bottom of the os sterni, and often more inclined to the left than in right side. It likewise is very frequently extends from the breast to middle and left arm. You see such an detailized and such as correct doctor nearly a little bit less than 300 years ago characterized clinical pictures and name it like angina pectoris, and we use this term till today. Clinical picture from nomenclature and criteria for diagnosis of disease of heart and blood vessels. It is younger, it is the last century, but it is historical information too. In this syndrome, the major symptom is thoracic pain, which is precipitated usually by effort but sometimes by excitement and heavy metal or exposure to cold. The pain is usually substernal and just to the left of the sternum. Occasionally, the pain is epigastric, and in rare instances, it may be localized in the neck or the left arm or shoulder. Yes, more accurate, more short, not such a detailed, but very good explanation too. There is a tendency for pain to radiate most frequently to left shoulder and arm, and occasionally to the fingers of left arm. Less frequently, it may radiate to the neck, to the jaw, to the teeth, to the back, upper abdomen, right shoulder, and arm. At times, the pain will start at one of these points before focusing on anterior surface on chest. The intensity varies from slight sense of heaviness to severe crushing pain. Since the precipitating cause is commonly physical exertion, rest usually causes the pain to subside. The length of the episode, therefore, is relatively short. Occasionally, an attack may come on while the patient is at rest or even when asleep. The pain is often accompanied by sense of choking or inability to breathe, which is also relieved by rest. The patient will often complain of flatulence as well. Today we can add for this description of clinical picture just one moment, that pain relieved by rest or by sublingual nitroglycerin. If the headache is not relieved by rest, it's what I told, the nitrate and last for an hour and more, and especially if it is accompanied by circulatory collapse, myocardial infarction should be strongly suspected. Occasionally, the pain of myocardial infarction may be identical with the pain of the anginal syndrome. The associated symptomatology and subsequent course will determine the diagnosis. Yes, one more time, clinical picture of angina pain. Yes, it is a pain with specific character. It is substernal. It can be shaped a little bit to the left, mostly often that provoked by physical activity, most often or stress. That can irradiate to the typical places. It is left arm, and typically it can be in left part of neck, left jaw, left clavicular, left part of back, and epigastrium, and more rare, non-typically, but possible too. It can irradiate in another parts of body. It is right chest, right arm, another part of abdomen, right part of head, all possible. More of it. This pain not very long. It usually lasts 10-15 minutes, and it's stopped by the rest of patient or by using of nitroglycerin sublingually. I show you this picture in previous lecture about general cardiovascular investigation of patient. It is differential diagnosis of chest pain. How to different cardiac from pleuritic from traumatic chest pain. By description, onset, location, other signs and symptoms, and relief. All these characteristics we include in mnemonic dollar. What is typical for cardiac pain? How to differentiate that it is angina and not other chest problem? Yes, for cardiac, by description, it is heavy, tight, squeezing, or dull pain most often. By onset, it usually gradual for angina, but it can be sudden, for example, for unstable angina and infarction. It can start in with exercise in angina or in rest for infarction and unstable angina. By location, it is poorly localized. Chest to back to jaw rarely changes with palpation, and no with position, no with breathing. It is non-changeable, constant, intensive pain. Other signs and symptoms. It can be diaphoresis, it can be palpitations. And by relief, it is relieved by nitrates. It's typical for angina, for stable angina. It is unrelieved with nitrates, what is typical for unstable angina and infarction. It is poorly relieved with non-steroids, non-steroid anti-inflammatory drugs, and poorly relieved with position of body. Here a typical clinical picture. Another sign, it can be shortness of breath. It goes in second place after chest pain in patient with coronary insufficiency. More of it, we should remember that it can be silent form. It is forms of angina and even infarction without pain. And in this patient, shortness of breath and dyspnea goes on first place in clinical picture and very, very important for diagnosing. It can complicate by different emergent disorders, and most danger for it is ventricular fibrillation. It is non-effective, a very fast constriction and non-synchronous constriction of ventricles that lead to nearly stopping, decreasing and stopping of circulation of blood in the body. And it lead to clinical death and need a very emergent case, like a very emergent treatment like CPR. And here you see ECG strips. It is ECG recording of ventricular fibrillation, and it looks like some chaotic line without any rules, without any specific forms of waves, just chaotic and non-synchronous constrictions of ventricles. Next sign, it is nausea. It is non-specific too, but very, very often sign of ischemic heart disease. Next sign, it is sweating. And really a lot of patients with pain forms and with silent forms undergo very intensive sweating during angina paroxysm. Diagnosis. For diagnosis, we use simple electrocardiography. It is stress test. It is electrocardiography after some stress, physical or pharmacological. It is echocardiography or heart ultrasound, including stress echocardiography or ultrasound after stress, and intravascular ultrasound. I showed you all these methods in general lecture about cardiovascular investigations. Additionally to it, it is coronary angiography that for today it is a gold standard of diagnosing of coronary artery disease. It is radioisotope scanning, visualization, and blood test. And here you see a scan with algorithm of diagnosing acute coronary syndrome. How to diagnose and what to do. You remember that it is emergency and we have minutes for all our manipulations, for all our corrections. We have just 10 minutes in out hospital stage to put diagnosis, to suspect acute coronary syndrome and start effective treatment. Electrocardiography. What we see here, as usual, 12-lead electrocardiography of ischemic. Here we see anterolateral ST segment depression in patient with coronary artery disease. It is a patient with stable angina, and this recording was fixed in moment of angina paroxysm, and we see that all anterior surface and responsible for anterior surface. It is V2, V3, V4, V5, and we see here it. All these anterior and lateral surface undergo ischemia, undergo hypoxia, and on ECG it looks like ST depression. Who has difficulties with ECG interpretation and basic moments about ECG, you should know about them on third course. We include in our program additional ECG course. It is basics of ECG. It will be available in Moodle. And now we have first testing course with 30 students. We start this course, but in future we will repeat it for another students. That's why contact to other teachers. They will include you in registration in further courses about ECG interpretation. And this study year we will have several more interesting additional courses that we don't have time during classes discuss with you, learn with you, but we can give it for you like additional not obligatory courses. And here you see like complications, what complications and especially what ventricle arrhythmias we can see in patient with ischemic heart disease, like a result of ischemic heart disease. First strip, it is normal sinus rhythm. You see that it is normal P wave, QRS complex, T wave, all segment on either line, all is okay. Second, it is not arrhythmia, but it is conduction disorder that we name bundle branch block. And according to where it starts, and it won't lead, on ECG, 12-lead ECG, we can find this M shape. It can be left or right bundle branch block can be diagnosed. Third strip, it is premature ventricular constriction. You see that all complexes nearly okay, normal size, normal form, but one complex is premature, it is earlier than normal, it is without PV and with very deformed, very ugly QRS complex, and after it usually goes some pause. We name it ventricular premature beating or ventricular extrasystole. Next, fourth strip, it is starting of ventricular tachycardia. Yes, it goes with big waves, but all of these waves are symmetric and have the same forms. It is ventricular tachycardia. Next strip, it is long QT syndrome with torsado de Poin's arrhythmia. It goes with like a symmetrical waves. It usually looks like a flutter, ventricle flutter, but if flutter goes with the same size waves, here we see periodically increasing amplitude, decreasing amplitude. One more time, increasing amplitude, decreasing amplitude. It is a typical ECG view of torsado de Poin's arrhythmia. It is a result of long QT syndrome. And last one I show you in real ECG in previous slide, it is ventricular fibrillation. It just chaotic changes of line without any significant waves complexes. One more example for you, it is ventricular tachycardia in torsado de Poin's. You see periodical increasement and decreasement of amplitude of changed QRS complex and no P waves at all. What is stress test? Stress test we usually do to provoke angina paroxysm. We told that angina paroxysm and pain syndrome, it usually starting after some activity. And in rest, or for example, patient come to doctor, rest for some time, we do ECG, it's all okay on ECG. Can we diagnose, exclude stable angina? No, we can't. We understand that it can start it after some stress. And for it, we have, for diagnosing it, we have a stress test. I told you that it can be a physical stress test or ECG after physical activity. And if it is impossible, we can do pharmacological stress. when we pharmacologically can provoke some changes on ECG. And here you see a photo of treadmill test of patient with stable angina. You see on the first three before test it was normal ECG without any depressing, without any changes, and stress ECG after physical activity this man undergo ST depression. You see it but raw, but it provoked just after some physical activity on treadmill. Echocardiography. It is type of visualization of heart or heart ultrasound. On this picture you see left main stem coronary artery and proximal segment of left anterior descending coronary artery in color-coded transthoracic Doppler echocardiography. Direct visualization of coronary artery stenosis, like you can see here. The portion of mid-segment of left anterior descending coronary artery with color mosaic or sign of high velocity turbulent flow and stenotic sign. All of it you can see in color at this picture. Echocardiography parasternal short axis view. Here it is presence of pericardial effusion. Proximal part of right coronary artery is suspicious for dissection. You can see it like arrow. It is dissection of wall. Imaging plane is of axis of non-dilated right coronary artery ostium. Contrast echocardiography in apical 4-chamber, 2-chamber, and 3-chamber views. Upper panels demonstrating the extensive reduction of myocardial perfusion in non-ST elevation myocardial infarction patient. With angiographic triple vessels disease include acute occlusion of right coronary artery and left main stem stenosis. On 4-chamber view on echocardiography, diastolic at left and systolic at right apical frames at rest top. Peak, middle, and post-exercise bottom imaging in patient with a previous inferior infarction. Rest regional wall motions was normal, whereas apical hypokinesia developed at peak exercise asterisk, and had been resolved by the time post-exercise imaging was performed. We can do intravascular echocardiography. At left picture you can see normal coronaries. At right it is increased coronary intimal thickness. Here it is 1.2 millimeter. You see it by arrows, suggesting severe vasculopathy. And next step, I told you that it is gold standard of diagnosing today. It is coronary angiography. It is one of the most detailed picture of coronary arteries that we got from this method, and where we can find the spasms, the anatomical changes, obstruction by atherosclerosis, complete blocks by trombosis in myocardial infarction patient, etc. Cardiac catheterization and coronary angiography. This picture shows severe left anterior descending coronary artery stenosis. You see it in left panel, with stent replacement in a left anterior descending coronary artery. You see at right panel that it was done revascularization, opening of vessel by stent. And you see how it is changed picture of coronary arteries during coronarography. Here you see single vessel coronary artery disease. On left picture it is severe blockage, and after stenting it is opening and normal blood flow in this artery. Coronary angiography of a case with acute myocardial infarction. It is pictures A, B, and C. First and second time admissions in pictures D, E, and F. You see how it is changed after treatment, after revascularization. Radioisotope scarring, it is a rarely usable method, but it is possible. It is stress imaging by arrows demonstrate inferolateral and anterolateral left circumflex ischemia. MRI imaging. Ventricular remodeling, you can see here at this picture post-myocardial infarction. Here it is picture of positron emission tomography, an infarct zone of the entire left ventricular myocardium. You see by arrows it is at the left it is MRI pictures, and by PET you see that it is decreased color in this place. It is no accumulation of positrons in myocardial place. Diagnosing, let's continue. It can be done computer tomography with mild proximal stenosis with expansive remodeling and predominantly non-expansive plaque. Partially calcified advanced mid or distal stenosis. And it can be hybrid imaging when we use several methodics to better visualization, and even like at this picture, building 3D map of heart muscle and vessels, coronary arteries and aorta. Here it is a picture of patient with silent ischemia. Cardiac hybrid imaging integrating single photon emission computer tomography with computer tomography coronary angiography. And additionally, here not in the first place, but obligatory when you suspect ischemic heart disease, it is routine laboratory testing and especially blood testing. Here we should check lipid profile with LDL, HDL cholesterol, general cholesterol, and triglycerides. We should measure C-reactive protein like a marker of inflammation that is associated with atherosclerosis. You remember from pathophysiology that atherosclerosis, it is by nature inflammatory process, among other conditions. Lipoprotein A, an additional lipid test that may be used to identify an elevated level of lipoprotein A, a modification to LDL-C that increases risk of atherosclerosis. The test may be used in conjunction with routine lipid profile to provide additional information. In acute coronary syndrome, when patient clinically has heart attack, to exclude myocardial infarction, we should do blood test with checking cardiac enzymes. What cardiac enzymes most usable? It is troponin, myoglobin, MB fraction of creatine kinase, etc. It is a lot of enzymes that elevated in moment of infarction or in moment of necrosis of tissue, but all of them non-specific for myocardium. For example, AST, they will be elevated too, but they can be elevated due to liver disorders, kidney disorders, muscle disorders, and huge number of different other disorders. That's why for diagnosing of myocardial infarction, we need something that is specific for myocardium. And here the most specific is troponin. What is troponin? It is a very good test, but it has one disadvantage. It is a late test, and in very early diagnosing, which is what is very valuable for us. It is non-informative because it is too early to check troponins. That's why we have a little bit other. It is more early but less specific enzymes, like creatine kinase, and specifically it is MB fraction. It is more early, and the earliest one, it is myoglobin. It is the less specific of both of them, but it is the earliest. In first 30 minutes of myocardial infarction, it will be elevation of myoglobin. That's why, according to time after suspecting starting of heart attack, we can use all of these cardiac enzymes, and their elevation can say us about presence of myocardial infarction. Okay, for today it is all information for you. For your homework, please read more about classification, about objective examination, signs in auscultation, percussion of heart, about what is connected to ischemic heart disease. And next lecture we will continue more about acute coronary syndrome. I add some moments about chronic forms of coronary insufficiency. And for today that's all. As usual, I'm waiting for your names and number of groups in comments. If you have some comments or some questions, you can write here or in our department Facebook or closed group. We're waiting for discussion there. I will be glad to answer for your questions. For today, that's all, and goodbye.